here we resurface the kneecap, so we'll take the cartilage surface off. And everything we do is under the premise of a measured resection, so we're removing bone in the relative thickness of what we're going to put back in the cartilage, in the thickness of the implants we put back. So we're trying to do a resection which will match what they had. Like that. Still don't like it. Come on. That's better. Okay, so that clamp holds us still while we make our cut. Okay, so we'll size our kneecap so everybody comes in different shapes and sizes. And the thickness of the button that we put back here, 35, will match the size of her anatomy. Stop. So these are little lug, or peg holes that Jen has drawn there. And that'll allow for some fixation of our patellar button as we get to the end of the case, which you'll see later. So that's the preparation of the kneecap, okay? We'll put this little protective cap on there to cover that so we don't injure that during the surgery. And then we'll get a good look inside the knee here. Okay, Z retractor. So there's a bunch of different retractors. So that has this right-angled Van Homan. Then Jen has that Z retractor. So inside the knee, this is first good look. So there's no cartilage that's really left here, as well as down here. A fair amount of wear and tear that you see up through the top. You can see that all pretty well. And then this is the anterior cruciate ligament. So she still has a decent or a good anterior cruciate ligament. That's the only ligament that we substitute for during this surgery. So that's the one you see people get reconstructed with big surgeries. A knee replacement has anterior-posterior conformity, so front-back conformity enough so that we don't need to retain that. We can't really retain it on a knee replacement. There you go. And then this is the lateral or outside meniscus. Right? So there's a meniscus or shock absorber that sits around the periphery, and the lateral side of her was less diseased. So you can see this kind of C-shaped disc cartilage there. That's part of the cushion that sits in there. Let me just bang on a little bit. So cartilage on the end of the bone here. As I wrap that metal osteotome on the cartilage, there's good cushion. So you can hear that's bone, and then that's cartilage. So cushion, no cushion. And that's the process of wear and tear that you see that leads us to this point. So the femur bone is like a pipe, a hollow tube. Switch. And so we'll use that to our advantage. I made a drill hole in the end of the bone, opening up the pipe. And that pipe, we're putting a rod up the center of the canal. That rod lets us put a referencing, a cutting block on the end of the bone which references off of it. So we can use her anatomy to help set the angle of resection on the end of the bone. Okay, so left 5, 10, good. Okay, so we've made we fixed this cutting block to the end of the bone based off of her long anatomy of her femur bone. And so that makes for a more reproducible or accurate cut. So now we made that flat cut. That's our platform that she's going to stand on, essentially. So that's the fixed angle on the end of the bone. That helps set her alignment, part of it. Now we're going to size the end of the bone. So everybody comes in different shapes and sizes, right? Like we said on the kneecap, same thing goes for the femur. So we're going to size her, kind of like sizing a shoe. To check the interposterior dimension on her. And Trudy got a little bones in there. So, I'm gonna say, we'll probably put the 2 in there. So we'll do 2. Let's do 2. You got a ruler? I'm gonna check the rotation. Okay, so this cutting block goes on. Yeah, let me see the 2.5 chain line. So we're trying to put in the size that'll match her the best. And let me do a chicken cut here, so no pin, just cut and I'll pin it. So I'm just trying to make sure that we don't over or undersize her. She actually makes for a nice 2.5. Cutting's better there though. Let's try the 2 and I'll cut the row. See the 2. So I'm jumping back between the sizes just to again get her the one that approximates her bone the best. Okay, so once this cutting block's in place, we'll finish up the cuts on the end of the femur bone. Okay, so that's the cuts on the end of the bone. Now the end of the femur should match the inner dimensions of our femoral prosthesis, and depending if we have to make any adjustments for balancing purposes, then we may be done with our preparation on the femoral side. You guys got questions?
Hi, my name is Caroline. I'm from the group Coons. My question is, are there any other pre-operational procedures that the physicians themselves must follow, such as the frequency of practice before the operation itself?
So frequency of practice, so in other words, what's my training or what levels of sequence do we go through before we can get to this point? So training to do something like this is med school, undergrad med school, and then once you're done with medical school, you do a training program. So orthopedics is a 5-year residency program, depending if you want to do any other work besides that, before or after. So you can do, hold on one second. I did 7 years of training, did a fellowship in just doing this, where in my fellowship I did thousands of these, and then in practice you get out. By the time you get out of practice, I've been doing this in some form or another for years and years in graded levels of responsibility. So that's how training programs work, is you do a little bit under the supervision and then do more and more. Okay, so I'm going to show you our cutting block here on the tibia. The tibia is, we're making a cut referencing the outside anatomy, so we can see, different than the femur, we can see the center of the ankle is running the center of the tibia really well. And so this cutting block is referencing the external alignment of the tibia, trying to create a perpendicular cut to the long axis and a parallel cut to the floor. And there's lots of mechanical reasons why that's a good thing. And this cutting jig on the outside of the bone lets us do that very well.